Nationalist Road. And I've put some, should be four essays from some nice topics. A 10-year-old male patient presents to the clinic with complaints of abdominal pain, diarrhea, and weight loss over the past 2 months. He reports that he recently returned from a rural area where he was working on a farm. That's a small boy, right? On examination, the patient appeared pale and undernourished. Drug X is the drug of choice in the treatment of cystodes, which are the tapeworms, and flukes, which are the trematodes like cystosoma. Name X. So, what is the drug of choice? Symptoms described here are pointing to us that this patient might have a worm, like the abdominal pain, diarrhea, weight loss. The worms are eating the food instead of him eating the food that he has eaten. And then he returned from an area, so he went somewhere where there were these worms. He got them and then came back. And specifically, if we're talking about, let's say this person is from another person, and then say they are in the United States, we are going to rule out cystosomiasis because it is less common there. So even the drug that we use for cystosoma is going to be removed because more likely they don't have that. But for the rest of the world, where worm infections are common, we can think of that. Okay, so we want to treat cystodes and trematodes. We know cystodes and trematodes, we call these as flat helmets or flatworms. What is the drug of choice? Anyone that can help with that? Drug of choice for Prasquantal. Okay. Let me just confirm in case there's someone also that is saying the same. Anyone also that is agreeing to that? All right. So, Prasquantal. And then number two is saying, what is this mechanism of action? What is the mechanism of action for Prasquantal? Anyone that can help with that? Okay, so we know Prasquantal, what it does is that it's going to make, the worms have got a cell wall, right? So you are going to make the worm to be permeable to calcium, and then calcium will start entering the cell. When the calcium enters the cell, it is going to cause the worm to paralyze because it is going to contract. That is what calcium does. So that contraction is what is going to lead to death because of the paralysis. And then number three, how can you prevent inflammatory reaction due to dead parasites when using this drug? When you give Prasquanto, the worms are going to be dying, and actually they can die in large numbers. And these guys are going to release they have got antigens, and the body is going to come and start responding. So how can you prevent the inflammatory reaction due to those dead parasites after treatment? Anyone that can help with that? Thank you so much. So co-administration with corticosteroids. These guys are going to weaken the immune system. And then be saying after investigations, you notice the patient ingested food and water contaminated with tea sodium, tenia sodium, eggs, and you conclude he has a cystoscosis. What is the drug of choice for treatment of cystoscosis and cystic hyatid disease and can be used in the treatment of infection by nematodes? Anyone to help? Pardon? Albendazole. Thank you so much. So we have got two drugs which we call the benzimidazoles, mebendazole, and albendazole. Now, albendazole is the best when it comes to cysticercosis because it can penetrate and go to the central nervous system. It's actually better when it comes to lipid solubility. Mebendazole is not good. That's why albendazole is better. What is its mechanism of action? Anyone that can help with that? Mechanism of action for albendazole. So what albendazole is going to do is it's going to bind to the beta tubulin that is part of the, and is going to be selective to the fungi, to the worm, not fungi. So when it binds to the beta tubulin, what it's going to now do is that it's going to inhibit polymerization. It's going to stop these beta tubulins from coming together. That is how it's going to be able to help in treatment. Besides that, we know that this guy, the same mebendazoles, because one the mechanism of action of albendazole as well can get to impair glucose uptake by the worms, specifically because we said they can also be used by nematodes, right? So nematodes. And these guys that we've mentioned here are not nematodes. These are platyhelminths or flatworms. Remember helminths? We can divide them into two groups: platyhelminths or flatworms, and the nematodes, which are the roundworms. The nematodes, this is where we have got a lot of guys like uh, tinea itself. And then for the platyhelminths, that's where we're going to have the cystodes and the trematodes. The trematodes, these are the flukes, like cystoma. Okay, so we are saying besides albendazole bind to the beta tubulins and inhibiting polymerization, it is as well going to be able to impair the uptake of glucose. And if the worm doesn't take up glucose, it means that it's going to not have any ATP, because that's the way the body makes ATP. And the meaning of that is that without ATP, you can't contract. So the worm is going to become immortal. And then it cannot be excluded from the body. Right. And then number three, how can you enhance the absorption of this drug? So we are saying albendazole is the drug we're talking about. How can we enhance its absorption? Thank you so much. The co-administration or taking it together with a fatty meal. When can you use this drug in pregnancy? Can you use the drug in pregnancy? Yes. When can you use it? Actually, in animals, it has been shown to be teratogenic, but not in humans. So because of that, you only use it after the risk benefit assessment is done. You've proven really the benefits are beyond the risks. What are the serious but rare side effects of this drug? Albendazole. Hepatotoxicity for, okay. Mm, we can confirm that. Anyone who wants to confirm that? Of course, it has got a lot of side effects, but for Dr. Chidma, there are those specific ones she has pointed to. Yes, please. Ye- yes, yes. So those are the rare and most serious side effects: alopecia, someone losing hair, and granulocytosis. Right? Thank you so much. And then we can go to see another drug. Why? Pardon? Okay. So high doses, yes, they can cause hepatotoxicity also. Thank you so much. And then C, another drug Y is effective against the larvae and not the adult form of the worm, and the drug of choice in onchocerciasis, which is the river blindness, lymphatic filariasis, and tropical pulmonary eosinophilia due to Onchellella bancrofti. Name drug X. Thank you so much, ivermectin. What is the mechanism of action for ivermectin? So it's not too different from the way albendazole was working, causing not albendazole. Albendazole was preventing the uptake of glucose and the beta tubulins, like plasquanto, which was causing paralysis. But the paralysis caused by plasquanto is because of the entry of calcium. Ivermectin, what it does is that it's going to cause chloride ions to start entering the cell. And actually, it's going to bind because the worm has got these receptors, which are known as glutamate activated chloride channels. So when glutamate binds here, these are chloride channels that are going to be activated. And then what is going to happen is that chloride ions are going to start going in. There's going to be hyperpolarization. And that hyperpolarization is going to cause ionic paralysis. So paralysis can be because of depolarization or hyperpolarization. Specifically, this is ionic paralysis. And then after that happens, the worm is paralyzed, it can't move, and so you can extrude it. Hope that is okay. Number two, a 50-year-old woman, Mary, presents to the clinic for routine checkup. She has a family history of cardiovascular disease, with her father having suffered a heart attack at the age of 55. Mary has no significant medical history, but reports that she has been feeling more fatigued lately. On examination, her body mass index is 30. She's big, right? Indicating obesity. Her blood pressure is 150 out of 90. Laboratory tests reveal the following. You can see total cholesterol is 260, which is above normal. Low density lipoproteins is 170, which is above normal. High density is 40, which is below normal. Triglycerides is 200, which is above normal. Name any lifestyle modification that Mary should adopt to manage hyperlipidemia. Anyone that can help with that? Thank you so much. So, number one, exercise. She should be doing more of the exercises. Thank you. Anything else? She as well can consider a diet. Maybe she's taking food that has got a lot of this. Anything else? What are some things that predisposes a person to having hyperlipidemia? Smoking. So she needs to reduce or stop smoking if she does. And also alcohol intake, she needs to reduce or stop that because it as well predisposes a person to these bad effects. Okay, so these are the main ones. And then number B, drug Y is a drug class of choice in managing this condition. Remember, this person has hyperlipidemia, and drug Y is a drug of choice. It's actually a drug class of choice. Name the drug class Y, including its mechanism of action and major adverse drug reaction. What is the drug of choice in hyperlipidemia? The statins, thank you so much, or the HMG CoA inhibitors, also known as statins. What is the mechanism of action? If we use this, then we will even know the mechanism of action. Anyone that can describe? So these guys are going to inhibit HMG CoA, which is the rate limiting step in the biosynthesis of cholesterol. The meaning of that is that we are not making any cholesterol. And so if we stop making cholesterol, we are going to help because it's a problem. We have too much cholesterol. Besides that, it's also going to increase the cellular reuptake of cholesterol, the cholesterol that is already present in the blood vessels in plasma. What are we going to do with it? It will increase its cellular reuptake via there are going to be receptors, the low density lipoprotein receptors. That is the one it will use to be able to take the cholesterol from blood into the cells, maybe going to store them, and that's why someone is going to end up getting fat and such. Okay, so that is that. And then the question is also saying major adverse drug reactions. What are the major adverse reactions for statins? I think there are only two major ones. Anyone that can hear? Thank you so much. Hepatotoxicity and also myopathy. So problems with the liver and the muscle. So for myopathy, problems with the muscle, we can have myositis, inflammation of the muscle. We can also have myalgia, which is pain of the muscle. Besides that, we can also have rhabdomyocytis. This is where you've broken down muscle and then you start excreting it in urine. That's the rhabdomyocytis. Okay, and then 3 is saying name 3 other independent effects that the drug you have mentioned in one above have. What are independent effects of statins besides them being used in the hyperlipidemias? Anyone that can help with that? So number 1, they can be used in preventing a stroke. Anyone that have remembered anything else? Especially simvastatin, which is more readily available. Besides being used in stroke, the weakness of bone when you are removing bone, calcium from bone. What is the condition known as? Anyone that knows that? So osteoporosis. So what these guys, the statins do is that they will reduce the rate of bone resorption, and so they are going to lessen osteoporosis. And then the last one is that these drugs have got an anti-inflammatory action like the NSAIDs. So these are the independent effects for the statins. And then number 3, why are some drugs from one, which are the statins, taken at night before bedtime? Name any that can be taken at any time of the day. Anyone that can help? Why are some of the drugs taken before bedtime? Anyone? So some statins have got a short half-life, and because of that you want to take them at a time when the body has produced the maximum amount of lipid so that they can now be able to take that lipid and go and store it where it's supposed to be stored, right? And also to inhibit the further synthesis of cholesterol using those lipids. So in other words, the circadian peak of cholesterol, the time when it is highest is at night. And then The second part is saying name. So which ones are those which have got, we can even, okay. Which ones are those which have got a short half-life that we can even mention? We have got lamvastatin, simvastatin, and the fluvastatin. So these guys. And then for those that have got a long half-life, you can use this RAP. So you have got the R, the A, and the P. So you can mention any one of these. They are the ones that have got a long half-life. And so they can be taken at any time of the day. Rosuvastatin, pravastatin, atorvastatin. That's the RAP. And then drug Y can be combined with another drug A in order to minimize the side effects and complement each other's action. Name drug A and its mechanism of action. So what drug do we combine with the statins to reduce the side effects and also for synergism? Remember, statins are preventing making cholesterol. The drug actually prevents the absorption of cholesterol. Anyone? Niacin, vitamin B3, not really. So there is this drug, it starts with EZ. Anyone that can finish it? Ezitimab. Thank you so much. So ezitimab. You want to combine these two because you can see when you combine them, you are going to minimize the side effects and then they will complement each other's action. The statins are preventing making cholesterol. And then ezitimab is preventing the absorption of the actual cholesterol that is already there. So that's complementing each other's action for what is already made. And then number C, what class of drugs used in this condition can correct triglyceride levels with minimal or no effects on cholesterol? What is the mechanism of action? So those which only work on triglycerides and not on cholesterol. Anyone to help with that one? And the ending, Brett. The fibrates. Thank you so much. So fibrates will only reduce triglycerides and not reduce cholesterol. Okay. And then anyone to help with the mechanism of action for fibrates? So they are gone. Yes, please go on. Thank you so much. So they are going to bind to PPAR gamma receptor either in the skeletal muscles or in the liver, and then they'll be able to induce lipoprotein lipase. Lipoprotein lipase, when it is induced, it's a lipase, it breaks down. It is involved in lipolysis, so it is going to increase the breakdown of triglycerides. And when you break them down, it means you are reducing their number, right? So that's that. And then how can you increase the absorption of the drug in E? And when should you not use these drugs? Remember, it is the same enzyme. Yesterday, when we are talking about, was that diabetes? We, not the drug, but the receptor. We said that there is another drug that works on. Anyone that remembers the drug for the anti-diabetic drug? Pardon? The TZDs, right? Thank you so much. Yes, those guys. They're actually on the gamma. Yes. Even the fibrates are on the gamma. All right, thank you so much. And then how can you increase? I'm just forced to comment on this. Uh, there was that guy DPP4. Which drugs work on this guy? The incretins. Thank you so much. Okay. How can you increase absorption of drug in E, and when should you not use these drugs? Remember the drug, this is supposed to be in C. Yeah, so the drug that we've mentioned in C, how can we increase the absorption? Have we even answered C? Yes. What class of drug is used in this condition? And we've said these are the fibrates. Now let's go to D. Anyone that can help there? How can we increase the absorption of the fibrates? And when should we not use fibrates? So these guys are actually opposite to the question that we did on albendazole. Remember albendazole, if you want to increase its absorption, give food that contains this fat, right? But when you are giving fibrates, don't give together with food. More like there's a competition of which one is going to be uptaken. So you don't give with food. And don't give fibrates for someone that has got renal impairment, compromised renal function. And then, if you wanted to reduce plasma cholesterol without effect on triglycerides, what drug would you have used? What is the mechanism of action? Anyone that can help with that? What drugs can we use to reduce only cholesterol without effect on triglycerides? Niacin. Niacin actually, I would say niacin is the best of all these drugs. The way it works is that it's going to reduce all the bad cholesterols and increase the good cholesterol. I think there's a question we are going to attempt down here. So remember those guys which we call the sequestrants, the bio acid sequestrant. So those guys, they only work on cholesterol and not on triglycerides. Triglycerides, fibrates alone. And then cholesterol alone, we are having the bioacid sequestrants. And the way these guys are working, this is our blood vessel. So these guys, what they are going to do is that they are going to bind the bioacids in the intestines. You know that the liver produces bioacids and then takes it to the intestines so that it can be used in digestion of lipids. So if these drugs are going to bind to the bioacid that is present in the intestines, the meaning of that is that we can't digest the lipids that are in the intestines, right? So we can't. So what is going to happen is that there's going to be reduced hepatic circulation, because normally when you get to digest, absorb the lipids, they're supposed to go to the liver like that, And then they're going to be used again to make some more enzymes and other things. But then you have reduced the enterohepatic circulation because you can't absorb them. So what happens is that there is no fat that has been absorbed for you to be able to take from the intestines. Specifically, please consider it's from the intestines. You've not absorbed fat from the intestines to go and use it to make bile. So what the body does is that it is now going to start making bile in the liver using cholesterol. But the cholesterol is not the one coming from the GIT. It will start getting cholesterol from blood. And by getting this cholesterol from blood, you are reducing the concentration of cholesterol in the blood. So that's the basic mechanism. You bind to the bile acids in the intestines, and that reduces the enterohepatic circulation. And that after that, there's going to be now increased de novo hepatic synthesis of bile using cholesterol that is in plasma, and so you end up reducing the concentration in plasma. And then F is saying, why does the drug named in G have poor patient compliance? So why do bile acid sequestrants have poor compliance? Anyone that can help with that? Remember, we're not absorbing fat. You can imagine what that is going to cause. So there's going to be bloating, there's going to be constipation, and that makes the drug not to be, people not to be compliant to the drug. And then now G, drug X has very good effect on all plasma lipids. However, it has got little use due to limiting effects. Name drug X. Remember, this one has got very good effect on all plasma lipids. It is going to reduce the low density lipoproteins, the very low density lipoproteins, cholesterol. It is going to increase high density lipoproteins, but then it has got little use because of some limiting effects. Which one is the drug? Niacin. Thank you so much. That's the vitamin B3. It's also known as the nicotinic acid. And then what dosing makes drug X work on plasma lipids? You know, niacin is used as a vitamin. So what dosing is going to make it work as an anti-hyperlipidemia drug instead of working as a vitamin? So the basic answer is any dose beyond that one which is used as a vitamin. Dr. Jimali was mentioning it should be like one gram something, but anyway, we don't need to know numbers for now. Name the limiting side effects that make us not to use niacin. Anyone that can help with that? Limiting side effects? Thank you so much. So there's going to be cutaneous flashing, itching, and dyspepsia, right? How can you prevent these side effects? Those same side effects that we've talked about, how can you prevent them? Thank you so much. So we're going to take an NSAID. Specifically, we're going to take aspirin like 45 minutes before taking the niacin. All right, thank you. And then the next question, why should this drug not be used in diabetic patients? Anyone that can help with that? Why shouldn't we use niacin in diabetic patients? It causes hyperglycemia. And how are we going to relate it to diabetes? Okay. So the way the guy, of course, is going to cause hyperglycemia That's what the diabetes is basically about, isn't it? But the specific way in which it's causing that is that it causes insulin resistance. So insulin won't be working. Okay, we can go to the next. Number three, a 50-year-old male patient presents to the emergency department with complaints of severe headache, fever, neck stiffness. What does this microbiologist by now, just after seeing headache, fever, and neck stiffness, they can be telling what's happening there? For the past 1 week, he has a history of HIV infection and not on antiretroviral therapy. On examination, the patient appears confused and has positive Brodski's sign. Lumbar puncture is performed and CSF reveals elevated opening pressure, increased white blood cell count, a positive staining for Cryptococcus neoformans. Before we even go further, what do you think is the diagnosis here? I know this is not pathology. What do you think is the diagnosis? Thank you so much, cryptococcal meningitis. So A is saying a drug X is given that forms artificial pores by binding to ergosterol in the fungal membrane. Remember, X is binding to ergosterol and then it's forming pores. Name drug X and how you can administer it if adequate CSF levels are required. Anyone that can help with that? Amphotericin B. Thank you so much. How can we administer it if we want to have adequate CSF levels? All right, thank you so much. So we are going to give it intrathecally in the subarachnoid space. So remember these drugs, these are polyenes, and we have got two of them, the amphotericin B and the nystatin, which are binding to the ergosterol. Nystatin, the only problem is that it has got some forms of effects. These drugs are normally given IV, but then when you want to have enough CSF levels, you give it via the spinal cord because it has got poor absorption. Number two, name how does the fungi develop resistance to this drug? How does fungi develop resistance to amphotericin B? Thank you so much. Yes. So there is a reduction in ergosterol, and we know that ergosterol is where it was binding. And then number three, name a second drug that is synergistic to drug X in the treatment of candida and cryptococcal infections. What is its mechanism of action? So which drug do we combine with amphotericin B to treat cryptococcal meningitis? Flucytosine. Thank you so much. And then what is the mechanism of action for flucytosine? And that can help there. Inhibiting the synthesis of RNA, all right? Thank you so much. That's a basic thing there. So what it does is that when you give this guy flucytosine, it will undergo deamination and then it is going to be converted to 5-fluorouracil. And the 5-fluorouracil is now going to be the one that is preventing the synthesis of nucleic acids. Okay, number 4. Why is the drug named in 3? Why is the drug name in 3 of limited value, though it is less toxic than? Have I skipped a question? Name a second drug. Okay. name a second drug that is synergistic to drug X. Like we've said, that is the flucytosine. Y is the drug of limited value, though it is less toxic than the drug named in 1. So Y is flucytosine of limited value, although it is less toxic than amphotericin B. Okay, unable to penetrate cell or fungi alone. Is there any other thought on that? Any other? Actually, the main thing that Dr. Chidumayo has mentioned is when you compare these two drugs, flucytosine has got a narrow spectrum. It is going to only work for yeast and not most of other forms of fungi. Besides that, just narrow spectrum, limited. And then it has got high resistance in comparison to amphotericin B. That's why even if the side effect profile is better, it has got limited usage. Then B, infusion of this drug caused fever, chills, rigor, and hypotension adverse reactions. What is a term that refers to the side effects of the drug X? The shake and bake. Thank you. How how can you prevent these side effects? How can we prevent the shake and bake side effects? So for us to be able to prevent these guys, we are going to we should be able to test the drug before. So test dose before initiation of IV therapy. Remember we said amphotericin B, we give it IV, right? So before we can start, we're supposed to have a test dose and you determine which one is the right amount you should give. Besides that, you can use other drugs. Instead of giving amphotericin B alone, combine it with other drugs so that you reduce on the dosage of amphotericin B and that will lower these side effects. And besides that, you can as well give it together with antihistamines, NSAIDs, glucocorticoids, those other drugs. So actually not together, but you are going to first treat. So pre-treatment with antihistamines, NSAIDs, glucocorticoids, and then you can now give them amphotericin. Name the drug that can be administered to prevent the rigor. Remember, the rigor is part of the shake and. So, what drug specifically can we give to prevent the rigor? So, we can administer meperidine. It's going to help with the rigor there. What is a major dose limiting adverse effect of drug X and how can it be minimized? What is a major side effect of amphotericin B, which is dose limiting? Of course, it has got a lot of side effects, but dose limiting. Anyone? So this guy is toxic to the kidney. Now, if you follow the notes properly, you find that amphotericin B elimination is not affected by the kidney, but it is toxic to the kidney. Hope you get that difference. So it's nephrotoxic. So because of that, the way how you can minimize this side effect, you can load with normal saline solution, and you can as well actually the combining effect that I said on top It's actually based on preventing nephrotoxicity. On preventing the shake and bake, the most important thing that you want to do there is to test dose prior to initiation of IV therapy and pre-treatment with antihistamines, NSAIDs, and glucocorticoids, and nemaperidine. But to minimize the nephrotoxicity, that's where now you can load with normal saline solution, and you can as well combine the drug with other drugs so that you reduce on the dosing. It will reduce on the nephrotoxicity. Besides that, instead of you just using direct amphotericin B, you can use what is known as liposomal amphotericin B. It's just that the guy is more expensive, but it has got reduced side effects, and then you are going to use a much higher amount than the normal one that you use just for amphotericin B. But it is better, there's much reduction when it comes to the side effects. Then we have got this one. A 4-year-old boy is brought in by his mother because he keeps scratching a spot on his arm, which is growing larger. He has no fever or any symptomatic signs or any systemic signs of illness. You see a circular K50 sized ring on his right forearm. You diagnose him with tinea corporis, which is a ringworm, and prescribe topical nystatin. What is the mechanism of action of nystatin? Anyone that can help with that? Thank you so much. So bind to ergosterol, plasma membrane of ergosterol, specifically for the fungi, and then from pores, and then that to make the fungi to be porous. So fluid is entering and it can destroy the fungi. Nystatin is similar in structure and function to which other antifungal medication? Amphotericin B, thank you. What is the indication for nystatin? What is why is it not given? Why is it not given parenterally? So let's start with the indication. What is the indication for nystatin? Thank you. Yes, thank you so much. So it's more specific, it's limited than amphotericin B because you only give it topically for skin and mucous membrane infections. And why don't we give it parenterally? It is too toxic. Thank you. Too toxic. So that's the basic thing. Okay.